because this is a real built-up for the final program which would be there at Hyderabad. And Dr. Saurabh and Dr. Gupta for providing that platform for G-Spark. And Dr. Sangeeta, Professor Vikas, and Dr. Jatin, thank you for coming and being part of this G-Spark Antibiotic Stewardship. I'd like to start with something which generally is, there are two schools of thoughts. As you land in Mumbai airport, you see very high-rise building, and it's a financial capital, Bollywood and things like that. You also see huge slum when you land at Mumbai airport. And stewardship also has these two schools of thoughts. There are two parallel things. One group which says that they've done enough. They need to now get into either an artificial intelligence based AMR or use technology or use something else. And the second group says, ये वेस्टर्न साइंस है, हमारे यहाँ पे तो वैसे ही इन्फेक्शन बहुत है और हम इसी तरह से पढ़ाया गया है, इसी तरह से हैंडल करेंगे. So they are unfortunately trying to find that middle path. So let's see if we can. So how many of you, till this gets moving, how many of you have at least seen your institution antibiotic policy? How many of you have read that seen antibiotic policy? And how many of you are participating in its implementation? The speakers cannot raise their hand. So there is a lot which needs to be done, and there is nothing which is great to be understood. We are like COVID. This is going to be another pandemic. We have seen this. Every drug which comes in, there is a dry pipeline, no new antibiotic working, and there is anything which comes new gets its own resistance built very fast, and that doesn't excite the pharmaceutical industry at all. And then our practice pattern also has been extremely poor. And I've been working with the state of Kerala for a very long time, and now 7 states. Every time when we come up and show this, most of the physicians would say that please also take care of over-the-counter drugs, and please also take care of animal. Our point of view is very simple. Let's do human prescription for which we are trained, because we have overused, we have misused, and we have underused because of our knowledge. And then there are lots of, it's a complex issue. It is, we can keep talking about it, we can say that it is very difficult, it's very easy, I've seen this, I know the natural flora, and there is nothing much which we need to learn. But it's a complex issue because there is nothing, it is the prescription etiquette has to be basically changing as per the paradigm change in our microbiological flora. So there are good flora, good organisms which are available, but we give a lot of antibiotic and we disturb that flora. So we did this study in the state of Kerala, which is 99.8% literate, with the physicians, and 52% of them, they prescribe antibiotic because still the patients are asking, because this whole horde of hoarding the patient that they should not be referred or sent to somebody else, and because of that, this magic bullet, which is either taking care of inflammation, infection, is always added, and then investigations are very limited, because we are still working with total leukocyte count, we are still working with cultures, we are still working with CRPs and procalcitonin. There is nothing major biomarkers which has come in. And once it gets initiated, nobody wants to stop, because if the patient has improved, it just continues. There have been many drivers for AMR. It could be underdosing, overusing, it could be lack of information, because we generally don't send cultures, and the culture for sending cultures is not there. And that is how it adds on to the huge problem. And then there are travels, and you know about the NDM, New Delhi Metolactam, which was there, which created lots of furore. But then it is important for us to also understand that we don't have our structures in place. And then there are travels happen. So it's not just Haryana needs to work. It is all 29 states and union territories needs to work. It is globally everybody needs to work because there is lots of travel. It's not just the human travel. Pigs travel 7 times more than human, and that's again a huge because there are growth feeds which are given, and because of that there is a problem. So what could be strategy? Basically, we need to be very smart. So whatever we give, it should be very specific, measurable, accountable, realistic, and the theory has to be working. And right now, whenever we say that this is how you need to prescribe, the physicians might object to it, and there is a physician autonomy which gets broken because then you are telling them what to do. So this is a good program where you at least allow them to use whatever they need to use. If you have a fantastic ID team, adult pediatric, if you have a good microbiology team who would aid you to get this diagnosis done, so you start smart based on antibiogram. So one that is there, based on antibiogram, you prescribe the right prescription and then start focusing. And that is also good. So don't disturb physician's autonomy and you can keep doing, but then you need to stop, review and see if it could be changed. So front end and back end, don't do pre-authorization. If you can do pre-authorization, that's the best because nothing gets started, at least for reserve antibiotic. So there is an aware classification and for reserve, which needs to be reserved actually for use, and we see a rampant use of these antibiotics. So front end and back end strategy. And then there is lots of restrictions and various dose optimization, streamlining of your processes based on the culture reports which comes in, the decision support system which can aid you to take the right decisions can be adopted. Now, every time when the antibiotic stewardship is discussed, leadership comes into play, that basically there needs to be a good participation. Now, what happens with the administration or the management is basically they're looking at rupee. They're looking at return of investments. Attitude is definitely a problem. Many a times management is a copycat management because hospital X is doing something, so hospital Y will do something. And people like me do suffer from ADHD, attention deficit. So if you send 4 paragraphs in mail, the first 2 lines is read and that is all. So we are very used to just reading the conclusion. And if you give raw data, nothing happens. And we are the management in India is very happy with mediocrity. Excellence is not part of the game because it's all revenue and cost saving is one of those primary aims. Now what happens with the clinicians? They don't work as a team, though they say that they are a team. They work as an individual. There is a very disjointed communication, and I'll show we have done some ethnographic work. They are very hierarchical. The senior says what he needs to say. And then there is training, because with undergraduate and postgraduate, there is no renewal exam and nothing happens. What happens with the microbiology, and I will take an anticipatory bail here with Vikas. They are very cultured people. So whatever you send, a rubbish sample, they will grow something. And physicians are extremely happy because now they have something, because there was a headache, they were not getting a differential diagnosis. Microbiologists have grown. Now they know that what is the problem. It may not be the problem. So they are very cultured people. Unfortunately, the interaction, which is bench to bedside, is professed, done, not done at many a times. And then there is most of this time is this clinicians non-cooperative complaint. Nursing participation, they are very obedient people, and all of you are, and Bobby, fantastic leader, hardworking, very emotional group of people. But then there is attrition is very high, and their participation, because they are not trained, it's not going to happen. What happens with this group, which is fantastically trained, who have a huge experience, clinical pharmacists, but we don't want to take them. because again there is a cost and issues. But if you don't do an economic analysis well, they need to be taken, but because they save the cost hugely. There are other group of people who do this infection because we are not very sure about our infection prevention practices. That is why we give double antibiotics. So they are outsourced, not trained, they have no clue, and they wear an unsterile glove and touch everything under the sun and believe that this is infection prevention practices. What happens with the hospital information system? Because we just believe कंप्यूटर से हमको कुछ इन्फॉर्मेशन मिलना चाहिए एंड दैट वुड बी हेवन. जब तक हमने गार्बेज इन डाला ही नहीं तो गार्बेज आउट आता ही नहीं. सो व्हेन वी डोंट फीड इट बट वी बिलीव दिस माउस इज अ मैजिक, क्लिक ऑफ अ बटन में सारी इंफॉर्मेशन आएगी, नहीं आती, एंड देन वी डोंट हैव दैट इंफॉर्मेशन. ID physician, this is the group which we are looking for at least for antibiotic stewardship. They are the king and queens, but they are not available. There are very few, there are few fellowship, and they need to start owning the patient. They cannot be just advisory to the clinical team, because if they co-own the patient, the clinical team gets a lot of confidence and they're generally diplomatic. So what we need to drive in, because we have conducted lots of training हर hospital में mega style पे हो रही है, कोई impact नहीं आता. वो impact नहीं आता because we don't, training is not linked to behavioral change, and that is where we are stuck. And then we have built a new hospital in Faridabad. It's a spick and span hospital. We took trained nursing staff, we took trained faculty. From day one we have infections, we have multi-drug infections. So अगर इतने नए facility में attrition low है, और क्यों आते हैं? Because it is all there in the community. So we have partly lost that battle in the tertiary care hospital because we have concentrated, but it is all there in community. So just working in the hospital may not work. And then there needs to be a lot of work. So we need to build teams. I'll do it faster. What we did at our institute is we looked at donor-obedient model, structure, process and outcome. So all what you see in blue is structure, all what you see in green is processes, and then we kept monitoring how we are doing in red. But it was a multidisciplinary team which used to do it. So what we did, it is just not, and antibiotic stewardship is just not about following policy. You have to dig deep. Is loading dose enough? Is de-escalation was done? Is there any other duration, the right indication, right drug, right dosing, right frequency was followed? Because it is not just about following antibiotic policy. But what was very, very important is the rationality. Once you monitor, once the team is there, rationality improves, your morbidity, mortality improves, and my length of stays have improved. So if I kept all-cause mortality as my denominator, if my revenue per operating bed is 50,000 rupees, imagine the gains which I have if I follow just good practices. So what are the gains? It is close to 7 CR. If I follow good antibiotic practices, my gains is for with direct cost, indirect cost, opportunity cost is 7 CR, and we have published this in Infectious Disease Society of America's journal. And why I bring cost into this is because unfortunately जब भी हम बोलते हैं कि ये अच्छा practice करोगे तो लोगों की जिंदगी बचेगी, उनकी मौत कम होगी, हमें दिखाई नहीं देता तो हमें फर्क नहीं पड़ता. When we say, and including the top management also, this is the language which they need to understand. This is the language which immediately had an impact. But then infection control practices is also important. Just about antibiotic policy will not work, because the practices you observe and keep changing. What generally happens is this is the checklist which is always ticked. So there is an ethics in documentation from technical staff and nursing staff, because everything is yes, and that is why a silent observer is also important. And any wrong practices you need to immediately change, because they keep most of the things on the bed and give injections. We don't have a proper SOP, and that is important. This is also what we did, and we reduced our infection rate, and we realized that our training, which was 669 rupees, my return of investment if I do a good infection control practice is $236. So initially, when we started in Kochi, we had only one infection control nurse for almost 11,000. When I did this exercise, I was given 8 infection control nurse immediately. And that is where we need to drive good practices linked with all the outcomes, which is important. But then diagnostic stewardship is also important. जब तक sample ढंग से लेंगे ही नहीं, हम practice क्या करेंगे? And that is where we need to empower microbiology lab because they will not take what is not policy. So अगर 2 blood culture bottles नहीं आते, which are aerobic, anaerobic का ज़्यादा होगा role, Dr. Vikas would say. But if it दो bottles नहीं आते, it will not be taken because until unless you drive a good diagnostic stewardship and collect good urine sample and not send sputum, otherwise you keep treating which is not to be treatable. But then once we realize that antibiotic is important, we realize that anti-tubercular में बहुत गड़बड़ हो रही है. And then rationality for that is also important, and that needs to go back to the community and do TB-free villages. Once we worked on antibiotic and anti-tubercular, we also realized fungal is huge, and fungal is becoming a big problem, and that is a huge killer. So anti-fungal stewardship is also important. But then lots of time, अब colistin डॉक्टर लिख के चले जाते हैं, and they say कि पता नहीं कितना नेफ्रोटॉक्सिक है तो 3 million dose दे देना. So we have empowered nursing staff to always give, there are 9 or 10 antibiotics, to always give loading dose even if the JR, SR, assistant professor have not written, because that is the science, and science needs to be practiced and people need to be empowered. This is the clinical pharmacist at our, she has also just done PhD and has done phenomenally well. So antibiotic stewardship is just not done by anybody else other than clinical pharmacists. She interacts directly with the cardiovascular thoracic surgeon and recommends what needs to be done, not done. And our job is only to empower this group of people. We tend to follow every bit during the longitudinal stay of all chronic patients. When he come in OP, when he went to the home, when he got admitted, what antibiotic was used, when it got changed, what was the reason for change, and until unless that is a thorough discussion, we can keep discussing about emotional way of antibiotic stewardship, it's not going to work. This is a good work which we did about communication. This was an ethnography. Sociogram was the tool which we used, where we just monitored on the left hand side how does the doctor's team behave and communicate to the patient, because every doctor, including me, believe they are the best communicator in the world, and we color coded their communication style and we shadowed them during rounds, and we realized that we are a university teaching hospital which is not for profit, but it is, despite that culture, it is hierarchical in nature. The senior speaks and then that's it. There is no other participation, which is bad. We also realized that Western culture में बोलते हैं patient centric hospital होना चाहिए. For India, it is a carer centric hospital. Most of the time we communicate with the carer and less with the patient. And infection prevention and antibiotic is never part of discussion in any of the rounds, because once started, nobody wants to change it or discuss it or titrate it, and that is bad. So we shadowed, we drew this diagram, we went to the surgeons and said that this is how you behave. They were so angry that the whole thing got stopped for 3 months, because they were angry that why we are being shadowed and we are being monitored. But then we came up and we said that it's extremely important, and we restarted after almost 3 months of speaking to all of them, and now we are seeing some behavioral change which is happening. So it is just not about the doctors, the patient involvement has to be there, that they need to be scrubbed well, there needs to be a contact time for chlorhexidine wash, there needs to be education which needs to happen. The carer which comes with the patient is extremely important, because he or she also needs to know when the patient goes home, what needs, and when they are there in the hospital or when they go home. Whatever we did, we went back to the government and said that doing in just one tertiary hospital is not going to work. Every secondary and government hospital needs to work, and we developed a roadmap, and we worked almost for 10 years released clinical guidelines, released strategic action plan, and lot of data surveillance which was done. So we need to not do it just in our hospital, but take it across the state and work with all of them. We also realize that there is education problem because we are not being taught in our undergraduate, postgraduate days. So we went to the university, medical university in Kerala, 35 medical colleges. We changed their curriculum, and under elective and value added course, we made it mandatory for undergraduate, postgraduate, and house surgeons, antibiotic stewardship. We worked with 5 European university and 5 Indian university and did a curriculum on antibiotic stewardship and infection prevention in all this area because this doesn't exist. So until unless we treat and catch them young, it's not going to happen. But then we realized that we're doing this for the medical college, but then there are a large group of people, general practitioners, who are never been reached. So we reached out to Indian Medical Association, all 14 districts. We trained the trainers, and we have given a very, very simple app, and now they train a lot of people, and that's again working very well. So I'll end this. There are lots of application. Now, we also say that in animals we are using it. What we did in state of Kerala and now in 2 other states, we geotagged all animals. Now it is also a problem because in India, हर जने के पास 2 मुर्गी, 1 गाय अपने घर के पीछे होती है. So the farms are very small. In Western countries, they are big farms, runs into acre. तो उनके अगर 400 buffaloes हैं, so then it is very easy for them to manage. So in India, it is very, very tough, and that is how. So we banned colistin. Colistin एक growth feed में डालते हैं ताकि उनको infection ना हो. So we banned colistin. When we were banning, we realized that government cannot ban it because health ministry के अंदर भी नहीं आता, animal husbandry के अंदर भी नहीं आता और food के अंदर भी नहीं आता. So who is going to ban it? And now Kerala sells chicken. So अगर आपको antibiotic लेना है, you can just eat chicken because it is full of antibiotic, and you will love it. So now Kerala sells chicken which is antibiotic free, and we test. My last bit is this: there are lots of pharmaceutical medical representative who gives lot of antibiotics, antifungals to the doctor, and they are given in the clinic, and they expire, and it is then thrown on as a landfill, and that is what we pollute water, and we pollute lot of land, and we create lot of antimicrobial resistance in environment. So what we did is we had a green bucket campaign throughout the state of Kerala. All pharmacies, all hospitals, all doctor clinic will have it, and they need to only throw it here, and it needs to be incinerated. So there are lots of work which needs to be done, and antibiotic stewardship is everybody's game. So it cannot be just done by either the management or the clinical team or the ID or the lab. It needs to be done by you, me, and it also needs to be done by the public who is there. And there is where we can create a very, very safe environment for our children and grandchildren. Because this is the next looming pandemic, and we don't have good solutions. So thank you so much for patient listening, and thank you, Bobby, for inviting me.